Hi, it's Matthew Links here, and I'd like to introduce Belle Sass, a visiting medical oncologist at Alice Springs, who's done this talk on what remote GPs need to know about endocrine therapy for breast cancer. We use endocrine therapy for all stages of ER-positive breast cancer, and this talk is coming to you from Bantway, Alice Springs, which is our undercountry, and I'd like to acknowledge our elders past, present and emerging.
I'm Belle, medical oncologist here at Alice Springs Hospital, and this is what remote GPs need to know about endocrine therapy for breast cancer. We're going to run through why we use endocrine therapies, what you may see in your clinic, and what to do about it. Patients with metastatic hormone-positive breast cancer also receive endocrine therapy. It's actually the standard first-line treatment along with a CDK4/6 inhibitor, not chemotherapy. This typically controls the cancer for a few years, with the average being just over 2 years before disease progression and the need to move to a new line of therapy, which might be another endocrine therapy, chemotherapy. There are lots of options. It depends on the patient and the context. The important point is that these patients often live a long time, with a median survival of about 5.5 years, and yes, in oncology, that's a long time. Some patients live 10 years or longer with metastatic disease. Between the patients on endocrine therapy for early and metastatic breast cancer, there are a very large number of patients on these therapies for many years. When explaining endocrine therapy to patients, I describe how estrogen is a normal part of being a woman. Their cancer is using it as food to help it to grow. Their cancer tablet is reducing the amount of estrogen in their body, which starves the cancer of its food, making it less likely to grow back. So what do we use? Very, very broadly, premenopausal women get tamoxifen, a selective estrogen receptor modulator, and postmenopausal women get aromatase inhibitors such as letrozole and anastrozole. I'm glossing right over the exceptions and the nuance here. The other trick to know about is that we actually take high-risk premenopausal women and make them postmenopausal with monthly gaserelin injections, then give them the aromatase inhibitor. What you need to know about that is that that's a very intense estrogen annihilation strategy with a lot of toxicity. Let's talk about the toxicities of aromatase inhibitors, or AI. The most common are hot flushes and arthralgia. These can be intense and treatment limiting. The arthralgia tends to mimic an inflammatory arthralgia like you might see in rheumatoid arthritis. Early morning stiffness, worse with rest, better with movement, warms up when they get going. It's also important to remember that these patients are on these drugs for years and can develop other problems over time, like osteoarthritis. If the joint pain is worse with movement and better with rest, it probably isn't the AI. Osteoporosis can develop over time, sexual side effects and vaginal atrophy are reasonably common, and all patients need annual monitoring for hyperlipidemia. Tamoxifen also causes hot flushes and arthralgia, but maybe a little less than AI. It doesn't cause osteoporosis. However, it does carry a small but real risk of thromboembolism and endometrial or uterine malignancies. Any abnormal PV bleeding on tamoxifen requires prompt investigation to exclude this. The next two slides are patient-friendly versions of the side effects of these drugs that you can screen cap and use in your practices if you'd like. So how do you manage the side effects of these drugs? Let's start with hot flushes. Women on endocrine therapy can't have HRT because the whole goal is to reduce estrogen. Non-hormonal drug therapy advice is much the same as for women without a history of breast cancer. These SSRIs and SNRIs have the strongest evidence in this population. Avoid paroxetine because it might interfere with tamoxifen metabolism. There's also evidence for gabapentin, particularly for flushes worse at night. You can give non-drug therapy advice as per the Electronic Therapeutic Guidelines, or ETG. All of these drug regimens are from ETG. Data for use of the new non-hormonal agents like Veozah in patients with a history of breast cancer is lacking. The FDA in the US doesn't consider breast cancer to be a contraindication, but there's no current recommendation from leading oncological societies in this space. And always remember, if patients are struggling, if they want to stop their drug or they have stopped their drug, send them back to oncology because switching to a less good drug is better than no drug, and a lower dose of their drug is better than no dose. Patients remain on these therapies for years and it needs to be sustainable. For endocrine therapy-related arthralgias and other musculoskeletal side effects, treatment options are quite limited. Intermittent NSAIDs on bad days can be useful, as is advising exercise, which has been shown to be of benefit in a randomized trial. Duloxetine has some evidence, but in practice isn't used much. Acupuncture also has trial evidence of benefit, but often the only thing that helps women with severe symptoms is to change the drug or reduce the dose. As an aside, only tamoxifen can be dose reduced. A less good drug is better than no drug, and a lower dose is better than no dose. Sexual dysfunction is an important consequence of endocrine therapy. Patients can experience vaginal dryness, decreased libido, and dyspareunia. First-line management is non-hormonal lubricants and moisturizers. For patients with significant toxicity impacting on quality of life that doesn't improve with this, please refer back to MedOnc so we can discuss alternatives such as vaginal estrogen. Vaginal estrogen seems to have very little systemic absorption but needs a nuanced discussion and consent around the potential impact on their cancer risk. And again, we will talk to the patient about switching drug or reducing dose so that they can stay on treatment. AIs are associated with osteoporosis. All patients on AI should be advised to take vitamin D, get adequate dietary calcium or take a calcium supplement, and they should also be advised to do weight-bearing exercise. I direct patients to the Healthy Bones Australia website for further information. We do a DEXA at baseline and every 2 years while on therapy. If osteopenia or osteoporosis develop, please refer back to MedOnc so that we can discuss continuing, switching to tamoxifen, or stopping depending on their breast cancer and bone health risk. For all toxicities, if all else fails, send them back to us to discuss switching drug or reducing dose. We aren't scary. We promise we aren't mad at them for stopping their drug. We know it's hard. Please encourage your patients to come back and have a chat with us about their options. To summarize, the toxicities of endocrine therapy are real and can be treatment limiting. There are adjuncts that can be commenced in the primary care setting to help with these toxicities. Changes to endocrine therapy should be done via medical oncology. Please reach out if your patient is struggling. We would love to talk to them about what we can do to make their toxicity burden lighter, including via telehealth. Thank you to everyone who's reviewed this talk and to you, our amazing primary care clinicians who make what we do here in oncology possible. It takes a village to look after these complex patients. Reach out to us here in Alice Springs anytime, and you can let us know what talk you'd like to hear next here in the comments or via email.